Okay. Hi, everyone. Hi, everyone at home. It is so wonderful to see you. I hope you're enjoying your summer. If you're not familiar with our program, last year we just kind of started something on a whim, and it turned out to be, I think, a good idea and popular and a lot of fun. So we just kept on going, and we did it in the spring because why not? And then we decided let's do it again in the summer because why not? And then one of the ideas is originally we were doing a lot of wildlife center lectures. But I teach a lot of classes, and we thought, why not take a little bit of time aside and do some anatomy, because I teach anatomy and physiology for the nurses, especially because, well, two reasons. Um, we all have bodies. And so, like, it'd be nice if there was like a user's manual, like, oh, that's what that does, oh, spleen, turns out it does that, etc. But then also, and I'm sure a lot of us have been in this situation, where all of a sudden you didn't plan on that day, but you're in a doctor's office, whether for you or a loved one, and there's a test coming back, and it's a blood test or it's an ECG test, and all of a sudden there's like, here's what the ECG looks like, and someone's pointing this, and this isn't something you're familiar with, but maybe on that day you're making a decision which is important. And so I just thought, yeah, this is a class I often give for students. Why not just offer, A is kind of like a user's manual, just a little bit more understanding of what's going on inside your body. But then also, if you ever find yourself in a doctor's office or, the yearly physical, oh, here's the hematocrit coming back, here's the clotting factors, what do all of these things mean? So this was meant to kind of be with that type of structure. And as I begin, if you have any questions, stop me at any time. And I'll probably mess up a couple of times because I'll probably say, all right, and like on the exam, and then you have to remind me, no, we're not your class. This isn't an exam. So just, help me out with that part. So the blood. I am so impressed by blood. And if anyone feels that some of these videos I'd like to see more of, I have a YouTube channel at Dr. Jan 41, DRJAHN 41. And we can, and that's where these are coming from. Some of them are sillier than others. Like this one, it makes some very good points, but I decided I should try to do an English accent. I don't know why. So just, you can watch or not, depends on you. The point that I want to make is when you were about this big, nothing worked. Your brain didn't work. Your digestive system didn't work. I mean, your lungs weren't breathing, but your heart was pumping. So out of your whole body, the cardiovascular system, that was the first one that worked. So obviously it must be doing something important. And so I kind of thought we could talk about it for 2 weeks. The blood and blood test this week, the heart, and the ECG next week. And then the human brain and behavior. The brain is the most complex structure of the known universe. And then on our last day in the series, on the 18th, we'll start off with respiratory system, then get into digestive, and as far as we can go with, and we could follow your interest. Like if someone needed to talk about the urinary system for whatever day, we could cut the digestive system short, get into that. So if anyone would like the schedule, I'm holding it up to the camera so people at home could see it. Feel free, we can email it to you on the Cultural Affairs site. You can find it as well. So blood, let's start here. It does three things. One, it transports stuff, right? So like oxygen and carbon dioxide, they're exchanging here, but my muscles need them here, so I've got to get from here to here, all right? My lunch being digested here, but it's got to get all over. This part is making hormones for gonads, but they got to get there. So transport is an important function. A second thing that's really important is, don't take this the wrong way. Good. Okay. And forgive me if someone's at home, I just kind of muted every now and then just, but if you have a question, feel free to let me know. Your cells are empty. All right, in that, like if you go to a pond, those little critters in the pond, they're, okay when it's warmer, when it's colder, when the pH changes, but your cells die really Yes, thank you. Your cells die if the environment changes. Like, I'm going to say something. I don't want you to get scared. If your blood calcium goes up by about a third today, you die. If it goes down by about a third today, you die. All right. And so we have to, oh, is my camera doing something weird? Can you see me? Oh, no, my camera's your blood calcium has to be the same all the time. Your blood's pH has to be the same all the time or your cells die. That's the price they pay for being so specialized. So that's another thing that blood does, in addition to protecting us, as we'll see here. But in my class, I'm just going to shut the door a little. We don't talk about blood a lot. We talk about what's in your blood. All right. So the first thing that we do is blood, not a whole lot we can say. What's in the blood? So the first thing you do is just spin it down. So if you go to the doctor's office, we can't talk about blood. It's what's in the blood. First thing you do is just spin it. So if you were a patient, you could just let it sit and the heavy stuff will sink. But if you're not patient, you put it in a little machine, a microfuge or a centrifuge that spins it. And it separates it into 3 layers, okay? Plasma up top, a buffy coat, and then your red blood cell layer called the hematocrit. Let's talk about this one first. The plasma is cell-free, all right? So there are no cells there. It is mostly water, but there's a bunch of proteins, all right? And so a lot of these proteins are made by the liver, all right? And so then sometimes you're getting, you're checking on your globulins. Antibodies would be here. So if you're testing, if you have antibodies against, something like COVID or Lyme or something, there are proteins that you could test from the plasma layer. I'll be talking about clotting factors in a little bit. That's kind of the end of this. Because if you've had a couple of mild strokes or heart attacks and you're saying, why? There are clotting proteins in your blood, and as we'll get to later, some people have more than others, just like some of us have darker hair than others, or some of us are taller than others. When we look at clotting proteins in your blood, we vary, all right? So it's about 7% of most people, but it could be a little higher, it could be a little lower. And so if you're worried about, like, what's my heart attack risk, we might look for some of those clotting factors. So that's your plasma. The buffy coat, it's called buffy because if you paint your house, there's like white, there's eggshell, there's ivory, and there's buffy. So it's like kind of a white color. That's where you have 2 types of cell-like things, white blood cells and platelets. But most of this is your red blood cell layer called your hematocrit. Now, I do want to talk about red blood cells, but before we do that, let's just go back to hematocrit. Okay. So that's an important measure in your blood. So if you get a physical, or if you're going to give blood, they want to know what your red blood cell layer is. What is your hematocrit? So, you can spin your blood down. And if you say, why would you want to know that? It's because it varies, right? So some people have a higher hematocrit. It's probably a little too high, but for exaggeration, I made it a little higher. Some people, it's lower. In men, it's higher. Male blood is thicker than female blood. The hematocrit, on average, is higher. As a result, men need a higher blood pressure to pump their thicker blood through their body than women need. So if you check blood pressure, in men, it's typically a little higher. And although both men and women suffer from heart disease, men tend to get a little earlier, and this is a major reason. Every single day, a male heart has to work a little harder, squeeze a little harder to pump a thicker fluid than a female heart does. There are other things that could thicken your blood as well. COPD. If you live at a higher altitude, like Denver or La Paz, Bolivia, where the air is thinner, like if you were to go to Denver, all right, and start running or doing your exercise routine, you would start breathing a little faster. Once I landed in La Paz, Bolivia, which is the highest international airport in the world, and we were all just sitting in the plane. Just the air was thin, there was less oxygen, and your body compensates by then starting to make more red blood cells, and you get thicker blood. Now, having thicker blood, there's an advantage to that. So let's say I just came back from Denver, all right? I might get a little cocky and say, tell you what, how about we all go in the hallway and race, all right? How's that? How about we all do a race? Well, see, I'm a little cocky because having come from Denver, if I have more red blood cells, that means my blood can carry more oxygen. I have a slight advantage when it comes to athletic competition. And that's why then with professional sports organizations, they worry, has someone been trying to artificially boost their red blood cells by the kidney hormone that tells the bone marrow to make red blood cells called erythropoietin. And there are ways of testing for this blood doping where you would try to give yourself an unfair advantage. That's important for the integrity of the sport. But also, if you're making your blood thicker and thicker, very often not under a doctor's care, at some point you're at risk as well. So that's a concern for multiple reasons. Hematocrit can be lower, all right? And it often is in women. So if you go to give your blood, you might notice that before they let you give your blood, they test your blood. And there are individuals who are told, I'm sorry, today isn't your day. You can't give blood today. And the majority of people are women because the hematocrit or the hemoglobin level isn't high enough. All right. And so, if you don't, have an abundance of, hemoglobin or red blood cells in your blood, maybe donating today isn't in your best interest. Other things like kidney disease and anemia, if you don't have a good diet, et cetera, could do that as well. Okay. All right. Well, I've been talking about blood cells. So underneath the plasma layer, we've got cells and another thing that's made by cells. So let's talk about that. And that gets us to the bone marrow. Right? So bone marrow is just really, really cool. You know what? I'm sorry. You don't appreciate bone marrow yet. Let's just go to a video on bone marrow so you can just watch. Right? So here's bone marrow. This, like, for example, in this part of your arm or this part of your leg, or maybe in some of your flat bones, you have this stuff. And these cells are special because they haven't decided who they want to be when they grow up yet. That's unusual for you, the adult. When you were a fetus, I mean, cells that hadn't decided who they want to be when they grow up yet, they were all over the place, all right? But we don't have that many of that left. So for example, I don't want a heart attack. I worry about that. I don't worry about cutting my skin so much. If I cut my skin, I'll just make new skin cells. But if I have heart muscle cells die, I'm out of luck. I can't make any more. I don't have the ability to make one more heart muscle cell in my life. I have all of the heart muscle cells I will die with right now. All right. So a lot of my body has decided who it wants to be when they grow up. The cells have decided who they want to be when they grow up. I don't get new ones. But here's the exception, all right, or one of the exceptions in your body. Because in this second, oh, hi, Mary Mulrooney. If you want to correct me with your nursing knowledge, feel free. Always welcome. So in a single second, you just made 2 million red blood cells, 4 to 6 million white blood cells, 2 to 3 million more, 2 to 3 million more, 4 to 6. So while some of my body, like most of my brain and my heart, I will never make a new cell. In your bone marrow, you're making new cells all the time. And the way that we do that is we give hormones to the bone marrow that tell them what we need. So here's a cell that says, I don't know what I want to be when I grow up. And if we give it one hormone made by the kidneys called erythropoietin, it will develop into what's called red blood cells. But if we give it other hormones, it will become white blood cells. All right. Now, when you were a fetus, you made blood in a bunch of places. By the time you were born, you only made it in your skeleton, but you pretty much made it all over in your skeleton. But as an adult, you only make blood in your skeleton, but not everywhere. There's specific places in your skeleton where you have red bone marrow. Like in my arm, this is the only place where I have red bone marrow. The rest has fat and is what's called yellow bone marrow. So that is where we are making blood. And let's talk about red blood cells first. So if you take a smear of blood, all right, it looks like this. So I'm just going to describe what I see. Red blood cells, red blood cells, red blood cell, red blood cell. Oh, well, look at that. Look, see, look. That's a white blood cell. Red blood cells, red blood cells. Oh, there we go. Another white blood cell. Okay. If we were to look closer, You'll see, oh, there's little smudges called platelets in between. But the point that I'd like to start off with, when you look at blood, most of what you're looking at are red blood cells. If you remember, that hematocrit layer was so much thicker than the buffy coat that had the white blood cells and the platelets. Now, you have a lot of them in a milliliter of blood, but I want to say this because it always blows my mind. If we were to count how many red blood cells there are in your body, give or take, maybe 25 trillion. If we were to ask how many cells are in your body total, I don't know, maybe like 100 trillion. In other words, like 1 in every 4 cells in your body is a red blood cell. Not only do you have a lot of red blood cells in your blood, you just have a lot of red blood cells, period. That's a lot of cells, all right? And they are special. So when they formed, they kicked out their nucleus, all right? So most of the cells of your body have a nucleus. They don't. They kicked it out, and that gives them this shape, which lets them squeeze through narrow capillaries and more space for gases to come in and out. All right, so when you go into a narrow capillary, they can squeeze through a little bit better. And not only did they kick out their big nucleus, they also kicked out the mitochondria, which that's the part of the cell that uses oxygen. All right, so when oxygen goes into a red blood cell and my red blood cell is going to my brain, the red blood cell, you can trust it to carry oxygen from your lungs to your brain because it can't use oxygen. Most of your cells can. They can use it for their own benefit. But if you kick the pink mitochondria out of your cells, red blood cells can only carry oxygen. They can't use it. So that makes them really good at that. So that's great. Right. And red blood cells are almost all a protein called hemoglobin. All right, so hemoglobin is kind of neat because it has a globin part that's a protein. That's the red or reddish part. But it also then has a heme unit stuck to it that has a big iron atom in the middle. So you get 4 of these things with 4 heme units, and that's what we call hemoglobin. And what does hemoglobin do? Well, it binds oxygen. Anyone impressed?
Yes.
Oh, good, 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 good. All right, for the people at home, they're not even trying to look impressed in this room. It's like I feel like I'm in my class again. And I get it why you're not impressed, because you're thinking, wait, lots of things bind oxygen. Iron rusts, it binds oxygen. That's true. But what hemoglobin does, it then also lets go. So that's what makes it special. Lots of things stick to oxygen. Hemoglobin reversibly binds oxygen. So you send red blood cells to your lungs, hemoglobin grabs the oxygen, you send it to your brain, it lets go. And that's the oxygen that your brain cells can use to get energy. So that's what makes hemoglobin special. And there's a lot of hemoglobin in red blood cells. All right, so just wrapping up some of the red blood cell stuff. If every second you just made 2 to 3 million red blood cells, that just means every second 2 to 3 million red blood cells just died. All right. So what do you do with all these dead cells? Because that's a lot of junk. And if like just cells were like if the streets of Middletown, like on trash day, if everyone instead of putting in their garbage can just threw the the garbage in the street, sooner or later it would be hard to drive. There would just be too much junk. And if that many millions of red blood cells keep dying every single second, we'd be in trouble. So there's some places like the liver and the spleen that eat old red blood cells. All right. When red blood cells get old, they just get less flexible. You guys don't relate. I do. All right. As I get older, I feel a little less flexible. I'm sure you don't. And so there are white blood cells in the liver and the spleen. Here they're staining black, which eat old red blood cells, so that you kind of control their breakdown. And here's just a test that you can pop up here and there, because I want to get back to blood tests from time to time. As we break red blood cells down, we process the heme. Like we'll keep the iron and we reuse it. And what used to be heme then becomes bilirubin. And since heme was pigmented, like blood has color, so bilirubin has color. This is pigmented, so this is why bile has color. Bile has a yellowish to greenish color because it has a breakdown product of heme. If we talk about the urinary system later, we test for bilirubin in urine. It shouldn't be in urine, and if it is, that means liver cells are dying. So that's a problem with the liver as they process this. Also then, as bilirubin then gets processed further, it makes two molecules that have color. So it makes the urobilin that makes urine look yellowish to orange, and it also makes stercobilin, which makes feces look yellowish to brownish. Right? So we process old red blood cells, and we can get those as a result. Now, let me just kind of do the 30-second version of this, and then we'll look at the clock, later on. And if anyone says, I really want to know the longer version, we can. But with my classes, this is something I often have to explain a couple of times, and this might take more time than we have. What you do is you have a protein on your red blood cells that you stick sugars on, and you decide which sugar do I want to put there. So there's a red sugar. Do you put it here or not? Well, if you don't put the red sugar there, you would look like you're blood type O, but if you get blood type O in a transfusion, you could die. All right. So most of you, that's rare. And where it happens, it's not this country most commonly. So I'm assuming that all of you have a red sugar there. And if that's the sugar group you have, you're blood type O. All right. If, however, you say, all right, let's start with that, and then throw on a yellow, all right, that means you're blood type A. Instead of adding a yellow, that means you're blood type B if you put on a green one. And if your mom told you to put yellows there and your dad told you to put blues there, then you have genes for each and you're blood type AB. So that's what it means. It refers to the sugar groups on your red blood cells. But why it gets into blood typing is you don't want to attack your own cells. We have diseases called autoimmune diseases where, all of a sudden, wow, it's my own immune system that destroyed all the cells that make insulin. That's why I'm a type 1 diabetic. Or my own immune system is attacking my joint lining. That's why I have rheumatoid arthritis. And so what we do is the white blood cells that we have in our bodies should not attack what we have, the sugar groups, but they are ready to attack the things that we don't have. So if I'm blood type O and you give me blood type A, my immune cells that make antibodies, they go crazy. They make all of these red blood cells blow up because they kill them, and getting back to the garbage in the middle of the street. Now I've got like blood vessels that are just clogged because I'm just killing millions and millions of the red blood cells I got in the transfusion. So it's important to get the right type of blood. And obviously we can go more into that, but that would be a longer discussion. So let's switch and go to white blood cells. All right. So the one crazy thing about white blood cells is they're not in your blood. All right, so I'm sorry, there's another program that nope. So let's come. So I showed you a minute ago that if you were to look in your blood, you would see white blood cells, but like one over here and one over there. So white blood cells are in your blood, but there's just not a lot of them. But if you were to look at, so I'm going to show you a bunch of slides of the tonsil, thymus, spleen, lymph node, Peyer's patch, and appendix. If you look at the tonsil, those are all white blood cells, all of them, every single one. If you look at your thymus, those are all white blood cells. If you look at the white pulp of your spleen, those are white blood cells. Your lymph node, your Peyer's patch. So you have gazillions of white blood cells in your body. They're just not in your blood. Some of them are, all right, but the overwhelming majority have left your blood and are now in the organs of the lymphatic system. All right, so I will say a little bit about the white blood cells. But if we're going to talk about blood, it's actually the lymphatic system that we talk about. Not to be insulting, but red blood cells, they're kind of stupid, all right, in that they lost their nucleus. They don't think. So where are the red blood cells going? Wherever the current takes them. White blood cells, I would, in my humble opinion, I don't think they're as smart as your brain cells, But I would say they're second. So in your body, if you ask what are the two most complicated things you got going on, I would say brain cells are number one and they're number two. They can leave the blood if they want. So they're looking for signals. So if I cut myself, I'm going to have inflammatory signals. And the white blood cells, they're going along through the blood and they say, ooh, there's a problem here. They're looking for specific chemicals. And under the right conditions, they leave for blood to go deal with the infection. So the ability to follow certain chemicals and the ability uh, to leave blood, that's something the white blood cells can do, but the red blood cells, they can't. Now, the white blood cells are all kind of transparent and they all look the same until you add dye. And when you add dye, they take up the dye and there's different kinds and there's different colors. All right. So once again, all of these could be like really long conversations. Obviously, in an anatomy 2 class for the nurses, this is not an hour. This is a bit more time. But just a quick synopsis. We have these different kinds, and if you were to ask why, all right, I would just first ask. I hope you feel safe. I want that, and let's just hypothetically say that you feel safe. If I ask you why do you feel safe, you might say, well, I'm protected. I mean, there's the US Army and the Navy and the Air Force and the Marines and FBI and ATF and CIA and state police and local police and campus security. And so there's a whole bunch of things, and organizations trying to make you safe. Why do we need so many? Well, I mean, they face different threats. So like the fire department and the US Navy, they both protect you, but from different things. All right. They are not interchangeable. All right. In the same way, what are you afraid of as far as infection? Unfortunately, a lot. All right. There's all these kinds of bacteria. There are these bigger cells called protists. There's viruses. There's cancer cells. There's toxins. There's worms. There's a bunch of things. So just like our society has firefighters, they fight this. The local police, they do this. The Navy does this. We have different kinds of white blood cells that kind of specialize. Like bacteria, that's their specialty. All right. Worms, that's their specialty. All right. Like if you were to have a fungal infection, you'd see a lot of those. Viral infections, they're really good at that. So that's why there are these different kinds of white blood cells. And one of the tests I'm going to talk about in just a little bit. Well, I'll tell you what, why don't I'll talk about it in a little bit, but let's go back to the hematocrit video. Sometimes, if you're just looking at your blood, one of the things that you could do is just like get a total white blood cell count. All right. So, if we have plasma, we have white blood cells in the buffy coat, we have red blood cells here. We could say, all right, I know I got white blood cells. How many? Like, let's count them. Well, as you might notice, this buffy coat's a little thicker than the first one I showed you. All right. So a normal buffy coat looks like that. This one looks bigger, and we don't do this anymore. We used to, as part of anatomy and physiology too, ask everyone to take the and we'd sample it. But then just, having blood everywhere, there's between hepatitis and AIDS, we decided, we'll err on the side of caution. We don't do that anymore. But one of the last times I did it, one of my students had just gotten over mono. And her buffy coat was so much thicker than everyone else in the class. Like everyone else in the class just got this hairline little white layer here. And hers was, and everyone like, how come yours looks so cool in my mind? Well, there was a reason. So if you count white blood cells, so if you get blood work done and you get a total white blood cell count done, the numbers mean something. This would go up if you have an infection. So like mono would raise this. And then also leukemia would raise this. Now, leukemia, let's just jump there. I'm going to show you something. I swear. There we go. Yeah, okay. Tell you what, let me show you one thing before that. I said that there aren't many white blood cells in your blood, but that's the wrong one. In a second, you're going to say that I'm a liar, that I've lied to you. That actually could be true. because the next couple of slides I'm going to show you, there's a lot of white blood cells there. All right. So you might say, you didn't say there was many white blood cells in your blood, but that looks like a lot to me. That looks like a lot to me. That looks like a lot to me. All right. Did you lie? No, those are leukemia patients. All right. So leukemia is a cancer. It's uncontrolled cell division where you are making too many white blood cells. If you were to look at the bone marrow of someone who had leukemia, look at all the purple cells that are making white blood cells. That's abnormally high. All right. And because this is coming from the bone marrow itself, this is where you might say, all right, patient of leukemia, we might have to destroy your bone marrow and hopefully find a relative who has a compatible bone marrow that looks so it's kind of like a fake ID. All right, like if you want to get into a bar and you're not of age, you not only need an ID, you need an ID whose picture looks like you. All right, so if you have a fake ID and the picture looks nothing like you, you're not going to get in. Same thing, if I'm going to put someone else's bone marrow in my body, I need that bone marrow to look like me. All right, because if it doesn't look like me, my immune cells say, this isn't you, and they attack it. All right. So when we deal with transplants, like any type of transplant, we look for compatible donors for that reason. So some tests just look at how many red blood cells do you have? What's your hematocrit? Is it too high? Is it too low? Some tests look at how many white blood cells do you have? Is it too high or is it too low? But then some look at, all right, let's count your white blood cells in the various groups. Okay. Now this was one of the songs that I started off with. Right, so just if you missed it at the beginning, we'll just white blood cell count. Numbers of neutrophils, many bacteria you must kill. Okay, so this is saying if we have these different kinds of white blood cells, and I'll name them if you want. So these ones are called the neutrophils. These are called eosinophils. These are called basophils. These are called monocytes. These are called lymphocytes. In a normal person, I'm sorry, I'm just getting a weird.
Well, somebody keeps,
Yeah. I'm sorry. If anyone wants to say something, feel free to throw it in the chat. But sometimes I get a background noise. I'll just mute that. So if I were to look at this, that looks normal to me. So what I do with I think I can do this. Come on, go away. In my students is I try to give them simulated results. So let me just go down to here. There you go. Let's go to it. Right. So if I were to ask my students, what do you think about this patient? The answer that I'm looking for is, looks pretty good. All right. In that, I know that some white blood cells look like this. They've got a weird number of lobes in their nuclei, and they've got faint lilac granules. They're the most common. So if you're saying they're like 50, 60% of your white blood cells, if I were to count 10 of these, and I'm like 1, 2, 3, 4, 5, wow, 60% of these are the neutrophils. Okay. If 56% of these were the neutrophils, that's normal. That's good. Oh, and look at this. 30% of them are these lymphocytes. That's good. That's the second most common. That's what I was expecting. The third most common is this big one called a monocyte. So this is normal. And I would look at this and I would say, oh, that's normal. But when you run blood work, sometimes each of these could be higher or lower. So for example, these are really good at fighting bacteria. If you got blood work done, something called a differential white blood cell count, and your neutrophil count was high, it's like firefighters. If I look across the street and all of these firefighters are going to the building, it gives me an idea of what's wrong. I think there's a fire there. If all of these ambulances go, to the building, it gives me an idea of what's going on. I think someone's hurt. If the US Navy is storming the building, I'm not quite sure what's going on, but it's not a fire. But so the same thing here, if the neutrophils, if they fight bacteria, if all of a sudden you have lots and lots of those, then you would say, not only do I know you have an infection, I think it's a bacterial infection. All right. Whereas if you had a lot of those, it might have been a fungal infection. If you had a lot of the lymphocytes, it might be a viral infection. And if someone's now trying to pick what's the next test or what drug do we give you to help you with your infection, this differential white blood cell count could help. All right. And so that's why, just going back to the, let's go to the fancy one. The different kinds of white blood cells. The different kinds of white blood cells. There are these 5 kinds. 3 of them, when we apply the dyes, they have what are called granules. So this first one, the neutrophil, has small, like light purple, we call them lilac granules. This one, the eosinophil, filled its granules with a red stain. The basophil, oh, so many of these big purple granules, you can't even see the nucleus. So 3 of the 5 kinds have granules. Then 2 of them don't. One of them no granules, but it's a little cell, mostly nucleus, that's a lymphocyte. And then one of them is a big cell that has no granules, that's a macrophage. And since they all do little different jobs, that then gives us an idea of what's going wrong. So eosinophils, they are really good at fighting worms. And I know that sounds weird to you because you're like, who gets worms? And the answer is, well, right now, a couple billion people have worms. It's luckily not something that's overly common here, but worms are a major cause of human illness and mortality. And so having a high eosinophil count, once again, if you want a medication to make you feel better from whatever's infecting you, that medicine for bacteria is different from the medicine for worms, which is different from the medicine for fungi, et cetera. And so this differential white blood cell count helps you distinguish between them. Now, I love white blood cells. Oh, white blood cells, they're the best. However, with everything in life, there is the balance, right? Like, we like heat. I mean, if it's too cold, that's bad. If it's too hot, that's bad. All right, I like iron. Too little iron is bad, but too much iron is bad. Even oxygen, like everyone thinks, oh, oxygen is the best thing. Too little oxygen, you'll die. Too much oxygen, you die. If I say, hey, everyone, let's go scuba diving. Here's a tank of pure oxygen. We're going down to 60 feet. You say no, because you'll die. All right, so everything's a balance. These eosinophils, all right, and I'm about to say this. I don't mean to knock them. But a lot of white blood cells, they're killers. That's what they do. So what they do is they walk up to a cell, they touch it, and they say, huh, do I kill you? All right, or do I let you go? That's their job. All right. Now, you might imagine they sometimes make mistakes and cause autoimmune diseases and cause tissues to reorganize. So eosinophil counts go up in a number of conditions we don't like autoimmune diseases, but like asthma. Like when you have asthma, eosinophils going up in your lungs, that's one of the first signs. And the severity of your asthma can be linked to eosinophils going up. So I love them when they do their job, right? But with everything, there's a balance. And sometimes they get a little out of whack. And that's something that you would want to test for as well. Okay, so those were a few thoughts on the white blood cells. Now I'd like to get to the third and final thing in your blood called platelets. Now I'd like to say that they're blood cells, technically not, because if we go back to that bone marrow cell that we had at the beginning, if we gave it erythropoietin, all right, then it would make red blood cells. If we gave it a combination of these hormones we called cytokines, it would make the white blood cells. But let's say we give it a different one called thrombopoietin, and it's one of the ones your liver makes, and the bone marrow can make it as well. What it then does is make these cells that I love, and I'll show you what they actually look like in a second, all right? And the cells get huge. Now, I'm sorry, I just always love this. A lot of people call these meta-megakaryocytes, which I think is hilarious because in Latin, meta means big. And in Latin, mega means big. So someone is telling you in Latin, this is a really, really big cell. All right. And so we make these big cells that then break into 1,000 pieces. And then each of those pieces is what we call a platelet. So while red blood cells are cells and white blood cells are cells, platelets aren't. It's like pieces of a much larger cell. I'm sorry, I love these guys so much that let's just look at them. Okay. All right. So that's a huge cell. All right. So this is one of those bone marrow cells that's breaking up into all of the little platelets that then go into your blood. All right. So here it hasn't decided who it wants to be when it grows up yet. But if you give it thrombopoietin, then it says, okay, I'll make all of these little things called platelets and release them into circulation. And they're small because they're not a cell. They're pieces of cells. And so if you look between the red blood cells and you see a little purple smudge, that is a platelet. Just going back to these for a second, most cells of your body have 2 copies of each chromosome. Sperm and ova have 1. Liver cells, they can have 4 or 8 copies of each chromosome, a little different. These guys, they can have 16 or 32 or 64, or sometimes in disease states even more. So they have more copies of chromosomes per cell than any other cell in your body. So they're kind of cool. All right. But they make these platelets, and platelets then get released into circulation. And so now we're going to talk about what they do. Before we get back to the platelets, if I were to cut myself, I want to stop the bleeding because I'm mostly fluid. I'm more water than anything else. So if I spring a leak, even a little one, that could be bad. So one of the first things I want my blood vessels to do is to squeeze so that less blood goes that way. It's like, there's a big accident on the road, you try to limit traffic going that way. So if there's a cut here, the artery tries to squeeze and with its muscle that's in the middle layer and say, send less blood to the injured layer. That way we will lose less blood. Now, along the way, then we're going to clot the blood, and it will involve these proteins. They're going to turn black here. So I'm going to talk about how a clot forms. I'm going to say something like, I don't want you to look at me any differently than you already do, but just let's be honest for a second. All right. This is my blood. I have bled for you. How many people giving presentations can you say that of? Just say it. I think I've gone the extra mile for you guys. Just say it. So how does the, thank you. Yeah. This is hilarious. I do that bit with my students. No one has ever clapped. That's a wow. Oh wait, I'm just gonna take this in. I'm serious. Thank you. So how does that happen? All right, so let's talk about how blood clots. Well, here's the platelets. All right. So what I'd like you to do is just kind of watch what they do on a normal day. And so you might want to watch because this is exciting. Okay, I just totally lied. It's not exciting. On a normal day, platelets don't do anything. When they hit each other, they bounce off. When they hit the blood vessel walls, they bounce off. And that's good. On a normal day, I don't want platelets to do anything. All right, so if platelets do what we're about to see on a normal day, that's, can lead to like an unnecessary heart attack or stroke or whatever. If I were to cut myself, I'm sorry, I see something in the chat. Okay. If I cut myself, however, I expose collagen. We got collagen everywhere. Like collagen is the most abundant protein in your body. So if I were to say you have collagen in your bone, look who's surprised. You shouldn't be surprised. It's everywhere. You got collagen in the dermis of your skin. Yeah, not surprised. Collagen makes up the white of your eye. Not surprised. Scar tissue, that's collagen. Like collagen is everywhere. All right, so it's the most abundant protein in your body. So if I cut myself, I expose to collagen. Platelets don't stick to each other under normal conditions, but they do stick to collagen where I've cut myself. And when they do, they start sticking out these little arms and grabbing their friend platelets, who then do the same and then do the same. And they kind of form a whole bunch of little platelets, hopefully forming what's called a platelet plug. All right, so before we go to the next video, pause next video. Let's just go back here. So platelets normally don't stick to each other. But here you can see a couple starting to aggregate. Here you can see a couple starting to aggregate. So when you trigger them, they can stick to each other. All right. And if you have a small cut, this platelet plug might help you to plug the hole. So you want to stop the bleeding. So that's good. But that's not enough if you have a big cut. All right. So the platelet plug just isn't going to cut it for a big cut. So the platelets, in addition to forming that plug, they let loose a whole bunch of chemicals. Some of the chemicals will cause that muscle to squeeze, that will limit blood flow to your wounded area. Some of it will help the area to regenerate, so we make new yellow cells so that we're not cut anymore. But then some of this then forms a clot. So I'd like to talk about clots. Okay. Now, while I'd like to talk about clots, I don't want to talk a lot about clots because there are some things that are like turning on a light switch. All right, so, oh, light is off. I flip the switch, it's on. It was like one or the other. There are some things in your body that we use the word cascade for. All right, so I'm going to show my little video because I like it better than what the textbook does. But we'll show you what the textbook does. All right, so how do we clot? It's not an on-off. Clotting factor 12 gets activated, which activates clotting factor 11, which activates clotting factor 9, which activates clotting factor 8, and this then forms a complex, which activates clotting factor number 10. So it's one turns on the next, which turns on the next, turns on the next. It's what we call a cascade. We have cascades when blood clots, and we have cascades in the immune system too. So there's a whole bunch of proteins involved, which then is why there's a whole bunch of bleeding disorders, all right? Because, I mean, we're all mutants. I'm a mutant, you're a mutant. So like I'm blood type O. I shouldn't be. I should be something other than blood type O, but it's a mutation that makes you be blood type O. So, you know, we have genes that don't work. There's all these different clotting factors. If you are missing a gene or one of these genes doesn't work or doesn't work well, now your blood's not going to clot well, and now you are at risk of hemorrhage. So this person might have a bleeding disorder because they're not making enough clotting factor 5. This person might have a bleeding disorder because they're not making as much clotting factor 11. 3 of them we call hemophilia. All right. And most of those are on the X chromosome, which means that men are more likely to get it. So if being a man, I only needed to get one gene for hemophilia in order to have it. So if my mom had given me a gene for hemophilia, I'd be a hemophiliac. All right. But a woman, if her mother gave her a gene to have hemophilia, if her father gave her a normal gene, she wouldn't. So women have 2 X chromosomes, so they need to get a mistake from both parents in order to have that X-linked disorder where a male only needs 1. So the majority of hemophiliacs are male. So if there was a test, and there's not, we'd have to talk a little bit about all of these clotting factors and the order in which they go. Et cetera. But let's just jump to the end, all right? Because you may remember when I talked about there were proteins in plasma, I named one called fibrinogen. Fibrinogen is this little tiny thing that floats in your blood. But at the very end of this pathway, what we do is we grab all of the fibrinogen, and now we turn it into these long threads. So it's not this little thing that's soluble in blood anymore. Instead, it looks like this. So all those strands, that's called fibrin, made of lots of pieces of fibrinogen. So a clot is made of something that's already in your blood, and you just then stick them all together. Okay. Now I want to get into blood tests, but just 2 little words here. So clots are great if you have cut yourself. But if you haven't cut yourself, clots aren't so great. All right, because they can block blood vessels. And I mean, that's bad because, you know, cells want blood to bring them oxygen. If this happens in my brain, I call it a stroke. If this happens in my heart, I call it a heart attack. And so I don't always like clots if it's forming unnecessarily. And there are 2 things I can do about this. If I'm having a heart attack now, because I have a clot now, there is something that I could take called a thrombolytic agent, something that would try to dissolve the clot that I have right now. If I have been getting clots frequently, I would take something, not a thrombolytic agent, I would take something we commonly call blood thinners or an anticoagulant that would just lower the clotting factors that I make. So I'll get to an image of this in a second, but all of these blood proteins, you're making clotting factor 8 right now, you're making clotting factor 9 right now, but all of us, we vary. So like some of us, our hemoglobin's higher or lower. Some of us, the melanin pigment of our hair is higher or lower. So with these, if you're making too much of these, let me just kind of say how we could test this. So if we were to go to this type of test, so I used to do this with students and then we stopped. And in hindsight, yeah, stopping was a good thing. But if you wanted to do this test, so this is a blood test that you could have done, you could get like a really big drop of blood. Someone stabs your finger, you get a big drop of blood, and you pull it into a little glass tube, a capillary tube. And then you wait a couple minutes and you break it. And you say, ooh, do I see it clotting yet? No. Okay. All right. So I'll wait another minute or two. Break it. Do I see it clotting yet? No. No, I'd give it another minute or two, but I could then wait. How long does it take for me to start seeing this blood clotting? Once again, it could take a while. All right. So in this patient, you had to wait like, 6 minutes or more, maybe, before the blood started to clot. The last time I did this with a class, I don't know, this is like 25 years ago or more. I remember her name was Mary. Like the whole class, we were just waiting for her blood to clot. And then we just gave up. We're like, all right, well, you'll get there. I just like, we don't feel like just sitting around watching you and seeing your blood clots. But the point is we vary and some of our blood doesn't clot quickly. That's good. And then we're at a low risk of heart attack or stroke. But you don't want to like pick fights that often, because if you get into a fight and you started bleeding, you would now be more likely to hemorrhage than the next person. In contrast, if we look at your blood and your blood clots pretty quick, like, 2 minutes or you're already clotting, or like, ooh, even under a minute. So you don't have to worry about picking a fight as much, all right? Because you'll clot the blood, so you won't hemorrhage to death. But if your blood clots really easy, well, it also then is more likely to clot unnecessarily and potentially cause a heart attack or stroke. Heart attacks, number 1 cause of death in the US and the world. Strokes, number 3. So clearly this is important. So if you were to get this blood test done, and you say, wow, my blood clots really fast. Or let's say, wow, I've had 3 little strokes, all right? Then you would suspect this. So you might say, I don't like how fast my blood clots. This is putting me at an added risk. So I'm going to take a blood thinner, which tries to reduce the number of clotting factors that I take. One of the things involved is when we make clotting proteins, we use a vitamin K for a lot of them. And so if you can inhibit that, you can, reduce these. So if I'm taking a blood thinner, all right, then hopefully I go from this, where my blood clots super fast, down to this. All right, so my blood doesn't clot super fast. So now I've reduced my risk of heart attack or stroke. But, and some of you might know this from yourselves and loved ones, but now you have to be careful of cutting yourselves or surgery, because your blood doesn't clot. You are going to bleed a lot. All right, so you've stopped yourself from clotting. So if you were to cut yourself, you're like, and even like little cut, I scrape my leg or whatever, you're just going to have blood, running down your leg into your sock to a greater degree than most people would. You have a question?
So, okay, say somebody has a clot, but they just had surgery and they're trying to heal from surgery. How can they take a like a blood thinner at the same time where they're trying to heal in another area?
So,
You know what I'm saying?
all right, I do. So I'm going to generalize in like 3 whole different ways, and I'm sorry if I ruin anything. But if you like hospital dramas and medical shows, all right, what I'm about to say is going to pop up as a plot line, I guarantee you. What you just said, different people have different approaches. So some people will say like, I'm a surgeon, I do surgery. Someone has said like, ooh, I'm an endocrinologist, I deal with hormones. And so on every hospital show I've ever seen, on one episode, someone decides we're going to try to give them blood thinners and deal with it that way. And then they're on the day shift and then they go home. And then the surgeon comes on the night shift and says, I'm going to do surgery. But because they're on blood thinners, they bleed a lot. And the next time these two characters in your show meet, they argue with each other. So my point is that pops up in a lot of shows because there are different approaches. Like if you were to see different doctors, you know, one physician might say, I think this is the best course. Someone else might go a slightly different way. So it's complicated, and I wouldn't, you know, jump in. And so, you know, if one of my students said like, I have this, what should I do? I just, you know, speak to your doctor. So you know, this is just general things, but it is complicated. It's not like this cut and dry, like here is the one thing to do. Okay, so as we wrap up, just so blood, there's all of these tests that you could do. So you could, let me just jump up to this one. You could figure out what blood type you are. So if I put antibodies in 3 little different spots, and I put then some of my blood in each of those, I could look to see if it clumps. And if I say, ooh, I don't see any clumping, I'm O negative. All right, but if I saw clumping over here, and I say, ooh, the antibodies that stick to A stick to my blood. I have A in my blood, so I'm A negative, it turns out. All right. And then you could, ooh, I'm AB negative. I am B negative. I am O positive, et cetera. So this is how you could determine what blood type you are. Okay. Now, one of the other things that I would go into with, a typical class, but the explanation takes 20 minutes. But once again, it's all in the videos I have is like who should give blood to whom, like why can blood type O get, this blood and not that blood, et cetera. In general, I make antibodies that attack what I don't have. So if I don't have A, I make antibodies which attack A because A is foreign. If A is in my body, it's not me. All right, so it's something that doesn't belong there. But if I ever get a transfusion with A, I'm going to attack it. So then the bottom line is, don't give me blood with an A in it. If I attack A, don't give me that. If I attack B, don't give me blood with a B in it. If I'm Rh negative and you have Rh positive blood, don't give it to me, all right, because I would attack it. All right. So let me just show you this because I mentioned this. So if you have heart disease, and we can talk about that next week with heart disease, the bad thing is I showed you what a blood vessel should look like at the beginning, where there's like this big opening. But if you start to have lipid plaques start to block up your blood vessels, and they could expose collagen. So if you expose collagen, platelets could start a clot there. Or if a clot started somewhere else because you've narrowed the blood vessel, the clot sticks there. Like if you've got a floating clot in your blood that forms over here, if you've narrowed a blood vessel, well, it's going to get stuck there. All right. So if this is what the blood vessels of my heart look like or my brain, well, now I'm at risk of heart attack or stroke. So you might want to stent or might a bypass to go around this. But we can talk about that next time. Just one other thing I'd like to say, and then I'll ask if you have any questions, is with the Rh factor. I said like your immune system can attack stuff. We worry about the Rh factor because the antibodies which attack the Rh factor can cross the placenta. If a woman is Rh positive, we don't worry about her. All right, because she's not going to attack an Rh positive fetus. She's not going to attack an Rh negative fetus. So Rh positive women, go have your child, you're all good. Okay. But if there's an Rh negative mother, okay, if the fetus is Rh positive, so let's imagine the Rh factor is white dots. If the mother makes antibodies that attack white dots, at first we're good, all right, because blood doesn't cross the placenta. But at birth, it does. At birth, there's going to be blood. And now the mother's immune system might touch white dots for the first time. And the mother's immune system said, what the heck are these white dots? These don't belong here. And then the mother's immune system says, from this point on, I'm going to be ready to fight white dots. And if this woman gets pregnant again with an Rh positive fetus, now her own immune system is making antibodies which cross the placenta and can cause a whole host of disorders in the fetus, including death. Now, this used to be a serious problem, but now women who are Rh negative as they're in late pregnancy, they are given RhoGAM, because this is the problem. Once the fetus's white dot blood touches the mother's immune cells, the mother's immune system, will act against it. But if you can stop that, if at birth you can clump all the fetal blood together and get rid of it, then you prevent that interaction from happening. So that used to be a big problem with the Rh negative women.
How
If
do
the
you
father
spell
was Rh
RhoGAM?
positive, this could be a disorder even causing death after the first pregnancy.
Siri, how do you spell the medication RhoGAM?
But because of RhoGAM, it's not an issue. Did anybody have any questions? So that was, blood in general, red blood cells, white blood cells, platelets, and blood clotting. All right. Any questions? Well, thank you. Thank you so very much. Okay, I'm going to hit one question and then I'll stick around if anyone has any other questions. Next week, we're going to talk about how the heart works and ECGs and about that. And once again, the goal of this is just you leave here and say, oh, I understand a little bit more about my body. And if I'm ever in a doctor's office for me and a loved one, and they're throwing terms around like hematocrit or differential white blood cell count, I might have to make a decision that day, that affects, health, care a little bit better informed. So that was the goal. Yeah, you had a question. It shouldn't affect the bone marrow, just the density of the bone around it. No, they should be separate. Yeah, I mean, very serious. That's getting back to the calcium in the blood. Oh, good. Oh, I'm so glad. Good. Thank you for that. Yeah, one of the things, and forgive me, this is always my example for osteoporosis. Every now and then you'll hear that someone who's in advanced age, more commonly a woman after menopause, breaks her leg in a fall. What often happens is that she took a step, her bone snapped, and then she fell. So while she did break her leg in the fall, actually her leg broke first and then she fell. So it's a bone density question. And the issue with that is our sex hormones do a whole bunch of things that are outside the reproductive system, including affecting the skeletal system. And after menopause, the ovaries become quiescent. So that's less estrogen to increase bone density. And you'd think, oh, well, let's just take more estrogen and estrogen replacement therapy. Then the problem is, though, but estrogen also causes cell division, which would then increase your risk of, say, breast or uterine cancer. So a woman in advanced age might say, like, what am I more afraid of? If I'm not afraid of cancer because it doesn't run in my family and osteoporosis is looking bad, maybe I do estrogen replacement therapy. But like if someone close to me had, say, breast cancer, maybe taking more estrogen isn't for me.
That's why we have,
Like I have a polio shot coming up tomorrow. I mean, the doctors have explained it to me, but it seems to me it's like gluing your bones together or something. But it certainly helps. Because
Okay.
I mean, I still do crazy things and stand on things to help when we're.
You want to demonstrate?
Show.
No, you can face it.
Show or something of an art show, and I've fallen a few times, and I've yet to break anything. I'm not saying it's a miracle, but I think it works. Of course, it's not great if you have to have a tooth removed and all that, but that's another factor altogether.
Thank you. Anybody else? I hope you have a wonderful evening. Next week, we'll talk about the heart.
Great.